Essentially, the letters that you see on the mask really are more about what country of origin they're from. So an N95 really is overseen by NIOSH and is usually an American origin. A KN95 is Chinese in origin. The FF ones come from Europe. Then there's another group that comes from Japan. But the most significant part of it is the 95 that's on it. 95 means that it essentially filters out 95% of the particulates. And that's what's relevant here. So I think while the United States would have traditionally used N95s, and that would be what commonly seen from NIOSH tested, that the KN95s from China would be in large part acceptable because it's the same material. The issue that you face is with all of these masks, doesn't matter whether it's from the United States or China or wherever it's from, Europe or whatnot, the masks really need to be fit tested, and that's not happening. It doesn't really matter if it's an N95, a KN95, a European model. It doesn't seem to matter because things are happening fast and furious, and we really don't have a ready supply of all these masks. We're finding that a lot of folks don't have them fit tested. And we actually put up, and OSHA had a great video about how to fit test, and we put it up on our website so people can view it. But in essence, you need that mask tightly fit to your face, very tightly fit to your face, because it's not supposed to have any areas where anything can come through the surrounding area of the mask, which is why you're seeing some pictures of staff with lines right around where the mask has been because it's so snugly fit. And different makes of different masks can be slightly different in the design and slightly different in the fit. So some might fit on some people better than others. So in the past, when we had plenty of time and you were being fitted, you might find that 3M made a mask that fit, and then somebody else had either a smaller face or just slightly structured, and they didn't find that it fit that well. So they might use a different type of mask, an N95, but a different supplier that had a little bit different design to it and fit another person better. In times where you're not in a pandemic and you have the luxury of time, you can say, well, that mask doesn't work for you, I'll switch to a different brand and we'll get you fit tested. None of that's happening now. I don't care if it's an N95 from NIOSH, if it's a KN95, really very little of that is happening in real-time basis. People are trying to get their hands on whatever masks are available. And right now with the CDC lowering the standard, basically saying we don't have enough N95s, we don't have enough 95s of anything at this point, we're going to allow you to wear a surgical mask. So if we're going to talk about whether or not a KN95 or an N95 or a European model is good enough, we have to juxtapose that against the fact that we don't have enough, and the CDC is saying wear a surgical mask. So if you give me a choice between an N95 or a surgical mask or a KN95, right, I'm going to say I'll take the KN95 if you don't have an N95. I'd rather have that than a surgical mask. A surgical mask isn't intended to stop viruses, and it certainly is loose fitting. It's not intended at all for what a respirator would be intended for. I think the biggest difference really is to understand that N95, KN95, one originates from China, an FF95 would originate from Europe, and an N95 would generally originate from the United States and be NIOSH tested. These other ones are FDA tested and tested as well. So if you get a certificate of a KN95 that's been tested, you're fine. And I say that because we actually, right now it's so difficult to get masks, and we knew that there was a shortage, and so we decided to go ahead and try to get some PPE for the nurses out there. And so we started vetting suppliers, and we had 2 outside epidemiologists working with us to look at the manufacturer. Did they already make masks to begin with, as opposed to changing over their factory from something else to making masks? And if they were making masks previously, what was the type of material that they were using? Were they actually stylistically a good fit for medical use? And did we feel comfortable that that's a product that we would be safe to put into the hands of our members? And we found at least 3 manufacturers that we were comfortable with that met the criteria for, was melt-blown cloth, which is what the N95s are made out of and is appropriate. So we ordered it, and so ours have a certificate that they're FDA approved, and it certifies the tests that they've been through. So we're comfortable that they're an appropriate mask for folks to wear. Now that's not going to change the fact that if you get a mask, it still needs to fit very tight to your face. So even if we can give you a KN95 that we're comfortable with, you're still going to have to make sure that you get that mask to fit tightly on your face, or you're losing the best properties of it as well. But again, if you're saying you get a surgical mask versus a KN95, I'll take the KN95. The Battelle machine is an experimental product that essentially looks to clean the masks that have already been used. Because when I mentioned the masks earlier, those are disposable. All of these masks were intended to be disposed of after use. And because there's such a shortage, that's not happening. So we have people reusing disposable masks, which is not a great thing. The Battelle machine was developed with the idea that you could potentially re-clean these masks to make sure that the virus was killed, and therefore you could reuse it. The problems with that, obviously, in any type of reuse of a mask is, whether it's this machine or something else, is whether or not you've caused any damage to the material that the mask is made of, and in doing so broken down its effectiveness of actually filtering the virus. That's number one. Number two is that you change the dynamics of the mask so that it no longer fits the way it should. And again, as I mentioned earlier, it's got to fit very snugly to your face. And if it doesn't do that because it's been altered in some manner as a result of the process, then that's problematic as well. The Battelle machine essentially is a company that's, as I understand it, a nonprofit. There's three of them that I'm aware of. One is in New York. They're based out of Ohio. One is in New York. One is here in Boston. And I think there's another one in California. I'm not sure if it's Los Angeles or where it is. But the company has apparently donated monetarily that any money that it would have cost to actually clean these masks to be reused would be donated. So the idea would be all of this problem that we have in supply of inadequate numbers of the N95 masks would be resolved because the masks could be cleaned and therefore people could reuse them again. I mentioned the issue with the reusing because of the fit, and also the reusing because of the potential damage to the actual material of the mask being potentially problematic. The other thing with this particular idea, though, is it uses hydrogen peroxide as a vehicle actually to clean the mask. First of all, hydrogen peroxide in its use as a cleaning mechanism, hydrogen peroxide is quite volatile. So you know, there's a little bit of concern over where you're going to put that type of machine in case anything untoward happens. I don't want anything blowing up anywhere. But other than that, too, it's, as I say, untested. All of them are untested, so we don't know whether or not this is really an effective way to actually clean the mask. We don't know that. But even if we were to assume that true, the other problem with the hydrogen peroxide is there's a real concern of the off-gassing of the hydrogen peroxide. So there's been, what little that we've seen written about it so far, is that that mask needs to sit for a period of time after it's been cleaned, potentially up to 24 hours. And again, this is all experimental, so we don't even know if that's enough. Because the concern is the off-gassing of the hydrogen peroxide can cause problems with the wearer, then putting the mask on and wearing it for potentially 12 hours straight then again. And when I say problems, it's a question of carcinogenic effect here. So are we actually having these wearers put on a mask that potentially could be a carcinogen in the end? So however well intended it is, I would keep in mind this is an unproven method of cleaning what is a non-reusable mask. And we're now asking health professionals that are already putting themselves in harm's way to wear something that is experimental at best and may actually cause injury in the end to them. So I think it is not malicious in intent, not at all. It is a well-meaning intent to try to resolve a big problem that we have, but I don't believe that we should solve one problem by creating another, particularly for the people that are putting themselves in harm's way already. I think we have to be honest with people. It's unproven, and we don't know whether or not this could potentially be dangerous to their health in the long run. So I think there's a lot more safety that needs to be done with this process before we put it in the hands of all of these healthcare workers who are going in and out of these rooms and for very, very long stretches of time. I think that's a mixed answer. I think some institutions are far better equipped to deal with this right now than other institutions, and there's a couple of things going on. One is, as we mentioned last week, I think that really The time was then to be designating which floors would be developed into ICU floors and to try to take the staff that had been not utilized because of all the elective surgeries being canceled, which was intentional, so that we could then use that staff to be trained up to assist with the expansion of the ICU beds and develop a plan for that. Some institutions did a really good job at that. They used all the the elective surgery staff that were not traditional ICU staff, and they began identifying the units that they would have the additional ICU beds, and they started buddying up the nurses and coming up with a plan to do that. And now those staff have a greater degree of familiarity about where they're going to be utilized, and a familiarity about the staff that will be with them, and where they can find things and how they can ask questions and do the best possible work for the patients. Having said that, there are other institutions that did not do that. Some had more of a plan on paper, but was not well communicated, and there was not training that was done. They are not going to be as well prepared right this week, for sure. And then worse, we have some incredibly bad actors out there in which hospitals, keep in mind, get a very large financial package as part of a larger economic stimulus package from the federal government. And the intention of that was knowing that because they had canceled all of these elective surgeries, which are a substantial portion of their revenue structure, that would be offset as if it was cost neutral. So they'll continue to see that they would get the revenue as if all their elective surgeries were continuing to happen. That would then allow them to redeploy that staff and to train them without losing the budget and the revenue that they needed in order to continue to stay open and to continue to pay staff. So if you have a hospital that lost revenue from elective surgery but now is getting that offset revenue, and yet we find them furloughing staff, or whatever furlough is, it's a term that we don't readily use in our contracts. You're either working or you're laid off, one or the other, and there's a mechanism to identify that and some rights and obligations they have. In this case, they're attempting to send people home that were used for elective surgeries because they don't have any. Well, they're receiving a financial aid in order to offset that so that they could redeploy those staff and train them so that we would be ready for the COVID patients in the best possible way. And yet they're not doing it. I think those bad actors need to be called out very significantly. I think our congressional delegation needs to be right on top of them and make it clear that do not expect the taxpayers to have offset your financial losses if you are not doing what is in their best interest to protect them with the pandemic. And just two other things that are going on that I think are worth mentioning this week. One is, because you don't suddenly grow ICU nurses overnight, right? And there's going to be a lot more ICU patients as a result of the COVID epidemic or pandemic. What we're doing is we're essentially buddying up nurses with those nurses that are ICU nurses. And we normally had what's called primary nursing, in which I would take an assignment, that's my assignment, and responsible legally through my license for the outcome of the nursing care given to that particular patient or patients under my assignment. Because if I'm a nurse that didn't formally work in the intensive care unit and I'm being rapidly deployed and trained up to help, that does not necessarily put me in the same position of being a well-trained ICU nurse ready to take the assignment and the full legal responsibility for it. So we're kind of creating these, I would call primary teams or primary nursing groups of RNs, in which we would have nurses assigned to other nurses who will take the primary responsibility of the patient, but then be with several of the nurses that will help with the workload of that patient population. They may not be able to do exactly the same things, but they can help coordinate the work with somebody that can basically be in charge of what's happening with that patient population. And so it's changing the dynamic a little bit. Some of the institutions are sort of suggesting we harken back to what was called team nursing, which is back in the 70s. I would remind people there's a reason why we don't have team nursing anymore, and that's because the outcomes weren't as favorable. And when we switched to primary care nursing, the patient outcomes improved dramatically. So there's a reason why we don't do it. Let's not make the same mistake of returning to something that wasn't effective before. Do I think that we have to change it up a little bit? Yes, but whatever changes we make should be done so with the frontline nurses that are going to be actually implementing those changes. It's going to be their licenses that are on the line, and they should have a say in how it works, and so that it works the most effective way for the patient. So make sure that if there's anything going on in that regard in your hospital, that you get right in front of it and have a say in what's going on, because it's your license that you're putting on the line as well. And the last piece of that, I would say, is the state has gone ahead and agreed to give licenses to senior students. I think that's a dicey concept already. I think that students, this is I think a difficult at best scenario for seasoned nurses who have seen a lot over the years and have a license. It's very different for somebody who's very new to drop in the middle of this. It's very easy to make mistakes in terms of infection control, cross-contamination, a number of issues that can, never mind the freewheeling, fast, rapid pace of trying to implement types of procedures that aren't normally used because we're in a situation where we're trying whatever we can to try to help these patients survive. Asking students to bear full responsibility for that is just completely untenable. So I'm not particularly thrilled with the concept, and I think we've made that clear. But if they are going to go ahead with it, one thing that has to be very, very clear is that there must be a senior licensed registered nurse who is in some way directly with that student, so that that person has a capacity to be able to ask questions and have other people intervene with assessment and knowledge base and to help them. So if they're going to be an adjunct to the patient care that we do, let's do it in the safest possible way. We don't want to lose these students, we don't want them to get sick, and we don't want to lose them to the profession by being put in a predicament that's just untenable for them, however well intended. I think we're on, the week, well, it's probably week 6, but week 5 of doing these short videos. And I had said at one point before, and I would like to remind the nurses to write diaries. I think whether they're video diaries that you do or written diaries that you do, I can't stress how important it is that you write some of the things that you're experiencing down for a couple of reasons, not the least of which is you need a place to vent it. We're trying to create some other mechanisms here, FaceTime through the M&A to have a conversation, some other support line to have that conversation that you might not be able to get into the specifics in a home setting or family members. You're not going to talk about these things in the same way that you could with other staff that you work with. So there has to be that, and there has to be a way for you to let that out, and I think a diary or journal yourself. And also I think after it's all said and done, you need to look back at it and figure out so that we're going to need this. And we talked about so it never happens again. When I say it never happens again, keep in mind that the Spanish flu went in several waves. The second wave was worse than the first wave. Whatever we learn from this first wave, we need to implement changes quickly and effectively so in the fall, when we see a second wave, that we do far better so that we're not in the same circumstances we're in now. You're going to rely heavily upon what you saw, felt, and wrote down in the moment, and we're going to need those voices to make the type of change that we're talking about. And I also think that I know that everybody's thanking you, but I think you need to hear it as many times as we need to say it, that you're being asked to do something that you probably never envisioned doing, and that we as a society did not give you what you should have had, which is the safest possible equipment, the training and preparation to be put in this position. You weren't given that. And I think at the end of the day, you are doing the very best, and we are all very thankful for what you're doing, because there's no question lives are being saved because of what you're doing, and that we're all thankful for that. I think the thing we'll push for you in this last round as well, and I know the testing, I know that's an issue. We're pushing as hard as we can that all of you should be tested. There's no reason in the world why we should be frustrated by the fact that if you are taking care of positive patients that you cannot be tested, so that you can have that sense of knowing for your family and yourselves, and also for your own patients as you go back into the facility. So you are right on that, and after this is all said and done, we should be able to have testing for everybody. Not only should we have it now, but also probably antibody testing when this is over, and we get that. I think that we're going to want to find out if you didn't in the moment have to get tested because you weren't symptomatic, but you think you might have had it. We want the antibody testing to find out if you're immune going into the second wave, which would be really good information you know. This stuff we know. We've heard it. We're listening to you. We are working on it every different way that we can, whether we're giving PPE directly to you or we are basically among every state rep, city council, congressional delegation, in the press, any way we can to push bargaining. Places are still doing bargaining over all of these issues in their facilities, and you guys are making a difference. You are making changes, and it's better PPE that you're getting in some places. It's better processes and policies in some places. It's preventing furloughing of people in other places. You are making a big difference from your standpoint of advocacy, not only for yourselves, but every time you guys do it, just like everything else you've ever done, you're making a difference for the patients. So from us all and from me personally, thank you for everything that you're doing.